Let's get this party started with an extremely powerful panel that will actually set the tone for the next 2 days. I'm thrilled to welcome our speakers to the stage for this official kickoff session. I'd like to introduce our moderator, the incomparable Pamela Spence, EY's Global Health Science and Wellness Leader, and the rest of our guests to the stage. Thank you.
Well, thank you very much, Jill, and thank you very much to everyone for coming this morning. So it's the decade of cosmic transformation, I think. Jill, you've just said, well, let's hope we don't disappoint. I'm going to just sort of frame, I think, where we are today in healthcare, and then we're going to have a 30-minute discussion with our panelists today, David Roux from Microsoft, Ron Park from Genentech, and Don Jones from the Cardiff Ocean Group. But let's just kick off. I mean, for me, healthcare, I think we're at a pivot point now. It's all around data. I think it's really interesting, the journey that we've been on, and many exhibits that are going to be in the halls in and around CES. For me, like, the real watch-outs are, where are those sensors now that are in us, on us, around us, that can actually start collecting health data? And of course, with the advent of 5G and AI, we now have the ability, for the first time ever really, to start really interrogating and making this data meaningful for us. We're also going to, we're really moving from a whole world of healthcare, which has really been managing and treating disease, into predictive prevention and even cure. And I think that's a really interesting topic too. So let's just get stuck in with some overarching themes. I think that the healthcare as we know it today, and many of the exhibits, of course, we're moving from hospital care into home care. That also addresses the affordability question. Data ownership, I think that's very interesting, used to be really the electronic medical records in an institution, but now it's moving into a very much diversified ownership structure, really with the consumer arguably at the center of it all. The reference point used to be the population. We used to treat healthcare in patient cohorts. We now have the ability to really get down to individual care. I think especially in the area of cell and gene therapy, which is not just for oncology, all areas and therapeutic diseases. The physician's role, I'm fascinated by this. The physician's role used to be one much more of an authoritarian type relationship with the patient, and it's going to become much more of a guide, especially as trust starts to be distributed, not necessarily in a paternal hierarchical way, but more distributed across social groups. And we see that, of course, with the advance of the internet connectivity and social media. And data analysis, data used to be very segregated and separated, and it's becoming much more integrated. And why am I fascinated about the data story? I think this chart says it all. Moving from 2018 to 2025, you can see the prediction, the quantity of health data that is expected to be in existence. That's quite a phenomenal leap. Of course, the ones of us who are a bit more environmentally and green conscious, we're not, at the moment we're talking about carbon footprint. I think we're going to be talking about data footprint in the environmental age going forwards. But really that takes us to a point, and I have many discussions with physicians. I'm an ex-scientist. But medicine used to be a clinical science supported by data, and I would argue at what point are we going to get medicine really being a data science supported by clinicians? I often talk to people about boards and strategy of where can I create and capture value in the future. And I'm a firm believer, and this is something I talk about a lot, the future value lies for those companies who can unlock the power of data. That's why this equation is I to the power of D. So unlocking the power of data by connecting disparate data streams, combining those data streams and sharing insights. And that's a very important point. sharing insights back to a wider community, but unlocking the power of data to fuel innovation in healthcare. And innovation can really only be measured in terms of the value of the health outcome that it produces and the degree of that personalization and arguably individualization of care. But I think the important thing here is no company has all the data that it needs on its own. And from an industry that has been typically very siloed, I do hope and trust in the future that the interoperability and the sharing and the creation of value is going to be much more fluid amongst different stakeholder groups. And that brings me on to an analysis of, I said to my team, well, show me some more interesting deals that have been done recently in healthcare, rather than the more traditional, more expecting type deals. I think this is really interesting, and just maybe picking out a few. You've got a very traditional pharmaceutical company or biopharma company, GSK, doing something with weather. How on earth does that make sense? But then you start thinking about, well, actually, a big focus of GSK is in the therapeutic area of respiratory. Actually, if you can put a smart inhaler together that has some sort of predictability about weather patterns, pollution levels, and maybe a double puff of your inhaler to prevent, again, coming back to not just managing and treating, but preventing an episode of asthma potentially occurring. I think that's very interesting. Moving down, I'm going to jump around a bit. Medtronic, a medical device company, doing something with Mercy. Mercy, really interesting, a hospital provider, but it's a hospital without any beds. I don't know how many people are familiar with Mercy or have even been to the facilities. Phenomenal establishment, but no physical beds. It's all telemedicine. And how does then Medtronic start to understand how its medical devices are performing to optimize the ability of post-operative care? I think that's also very interesting. 2018, Roux did a deal with Flatiron. Really interesting. $2 billion, that deal was. Flatiron were predicting the outcome, and maybe, Ron, you can correct me if I don't get this quite right, but Flatiron were predicting the outcome of clinical trials before they really had even got halfway through or 2/3 of the way through. Really interesting deal, not to share too many secrets about it, but the ability now that we have to predict clinical outcome with sophisticated data sets, I think is really phenomenal. The really interesting thing, though, about this collection of deals is you'll note that the type of deals there's only two acquisitions and one joint venture on this page. You wouldn't have seen that 5 years ago. It would have been all outright ownership. Many of the collaborations that we're seeing with the technology angle in them are more partnerships. So again, it's the sharing, that mutual creation of value across different stakeholder groups that perhaps wouldn't have transacted in the past. So I think, organizations in healthcare continually are seeking new skills, and skills that they wouldn't have traditionally had in the past. So I'm very optimistic about collaborations and sharing agreements, value equations coming together. As an ex-scientist, I'm fascinated by some of the sensors. I mentioned it earlier on, but I think this also talks about boundaries are blurring. You've got traditional healthcare companies, but now making much more sense to team up with technology companies or consumer companies. You have sensor-embedded pills. We were just preparing earlier on this morning, and we're talking a lot more about sensors inside us, and medicines and dosages can be switched on and off from the outside of our body, and measuring the really micro elements of our metabolism to see how any treatment is actually working. So I think the blurring of boundaries between the innovations and technology and value, there's so many different data points which really start to really make it a no-brainer for collaboration, which is, I think, what CES is really all about. And one of the last points I mentioned, I think this is really interesting. Where has disruption and technology taken us? And for me, everyone talks about disruption, but people don't actually talk about power shift. And for me, disruption is all about power shift. And we can see here, really looking at a life science perspective, for years and years and years, big sales forces at the biopharmas interfacing with healthcare physicians and providers. Really a lot of power. But look at how us as individual patients and consumers, we're more empowered, we have more access to information. New technology companies are making it easy for us to manage and support and be interested in our own health. And so the power shift that technology is creating for us as consumers, I think is very, very exciting. So enough from me. Let's get stuck into the panel. I'm going to ask each of the individual panelists just to give a 30-second bit of background about yourself, please, and then we'll get stuck into some of the questions. Don, perhaps you'd like to start off.
Sure. Don Jones, big, long term background in healthcare service provision, Chief Operating Officer of American Medical Response, the world's largest EMS company, and MCare, the largest medical group in the United States. And then 11 years at Qualcomm, where I helped build this industry starting in 2002, and what we now know as digital health. The last 6 years I've spent working with pharma and med device companies, smart apparel companies, all in the world of digital health as either a board member or an advisory board member.
Good morning, everybody. My name is Ron Park. I am the global head for personalized healthcare within, some of you know as Genentech, which is our US arm of Roux Pharmaceuticals, which is a global multinational. This is a company that has had a long history of working on personalized healthcare. We were one of the first companies to deliver targeted medicines for cancer. We've been doing that for 20 years now. Over the last 5 to 10 years, we have been increasingly excited by the advent of digital health and the value that data can bring to the mission that we have of discovering, developing, and bringing medicines to patients. And we really increased our focus on this over the last several years, especially with the acquisition of Foundation Medicine, which is a genomics company, and Flatiron, which is a real-world data company in the oncology space. We do believe that this is a new era. We believe this is something where we have to co-create together, because I would say no single industry here has the answer, and we're super excited to be engaged in this and really excited to be here at CES.
David.
Good morning, everyone. My name is Dave Roux. I'm the Chief Medical Officer for Microsoft. I'm also the Chairman for CTA's Health and Fitness Technology Board. A little background on myself: I'm a physician, I'm a technologist, I'm a health services researcher. I've spent really the past part of my career looking originally within the hospital space, provider space, how healthcare technology systems like EHRs could be used to improve care. Really saw the shift happening, as much as Pamela described, towards consumerism, and had an opportunity to serve as Chief Medical Officer at Samsung for the past 6 years. But where data is now becoming one of the core elements of where we're seeing the opportunities lie, both in terms of understanding how it can be better understood and be more predictive with that. The opportunity to join Microsoft and be able to look at that as an area of deep interest, not just for myself, but I think for the industry. We're looking at data as a platform, allowing us to be able to leverage cloud, AI, machine learning, and hopefully improve outcomes in the process.
Great, thank you. So guys, I mean, I talked a bit about healthcare traditionally has been managing disease. But what top 2 things do you think need to happen for a more participatory collaboration, maybe with or without consumer behavior change, to get healthcare really real and impactful change for the patient? Maybe start with you, Ron.
Yeah, look, I think from our perspective as a pharma company, the trends that we see here, and I was looking through the program, I see a lot of the apps and wearables and sensors that people are developing. I think we're really excited by this. From our perspective, our world used to be develop a drug, give it to a physician who would give it to a patient. Our participation kind of stopped at the point where we gave the drug to the patient. The reality of it is a lot happens after that has a big impact on whether our drug delivers the benefit to the patient that we expect it to have. And I think now that we have the ability to actually monitor patients, to understand what's happening with their diseases outside of the physician's office, this is a tremendous opportunity for us to be able to improve the impact of our medicines on patients. And if you're a patient with cancer, you want that. Right? You don't want to get that medicine that in a clinical trial in a very sterile environment seemed to work, but then in the real world doesn't due to all these different factors that happen in the real world. And the fact that we now are able to track this, to understand what happens in the real world to a patient, and things that really have an impact on whether the drug works in the patient or not, I think that is something that we're very, very excited about, and I think that's going to be something. I would object to that line that you had where the biopharma industry's influence drops. I actually would argue the more that we engage and work together, the more we're going to take the impact of therapeutics on human health to a totally new level, and I think that's super important.
But lines can be fluid.
Yeah, we'll work on that. The other, since you said for two, I think the other thing that I would just say, look, I think we see this throughout this whole session. It's a bit of the wild, wild west right now. There's just so much going on. I think for I just remember going to my physician last year. It's overwhelming for them. Right, and I do think one of the things we're going to need to see over the next 3 to 5 years is a consolidation and simplification of this, both for the patient and the physician. We cannot have a world where a physician's supposed to process a genomic profile, all the clinical data, image data, advanced analytics off the digital data, 5 digital apps that the patient brings in with it. They can't do this, and it's not going to deliver the impact in human health that we need. I think this is something that's going to be critical as we move forward. It's fine right now. We're sort of in the storming stage of the evolution of healthcare, but I think if we want to be practical about it and have an impact in human health, we're going to have to make this simpler at the end of the day for both the physician and the patient.
I think Ron touches on a really interesting point, this concept that our roles are changing. Mm-hmm. And when you even think of it from the perspective of clinicians or physicians, what we find is that historically it's been, you see me in my office or in the hospital, we treat you, and then you're kind of on your own. And the expectation is that you'll just take care of yourself, and hopefully we won't have the opportunity to see each other in an emergency situation. But the reality is a lot of times there is a need for continued follow-up, further connection to the patient, and support and mechanisms that allow that. So as we start thinking through how to redesign the health system to make it such that we align towards common objectives, the payment models, the systems of technology that allow us to become better connected, that's going to have a huge impact. And we're talking about payer, provider as sort of a key starting point, but it really does extend towards the consumer and even all the stuff that we'll be talking about later on today or in technology directly to the consumer. So that's going to be a real big part of where we see technology and really the payment systems applying to improve a greater alignment around this. But I think even from the perspective of the patient, there are some things that are probably difficult for patients to be able to address. You think about even just this concept of blue zones, areas in the world where people live longer. Why is it? They have a diet that's higher in plants, and they are really focused on exercising and doing activity regularly. They have connections, social connections. They have purpose. These are the types of things that in many ways are difficult for us today because of the fact that we are becoming more isolated, the fact that we are finding ourselves busier. So there oftentimes tends to be a need for us to be able to start looking at more holistically these social determinants of health, these abilities for us to understand how can we as society address these through programs and perhaps even technologies.
I agree with that. It's interesting, I've just come back from Ethiopia, Christmas and New Year. The average life expectancy in Ethiopia is 62. And I thought, we talk a lot about aging, and there's obviously a flexible model that needs to be worked to meet all the demands of different economies in the world. So it's not just about the Western world, of course.
Pamela.
I was just going to come to you, John.
Let me jump in here, because I take a slightly different view in terms of where this starts. Healthcare is the largest consumer market in the world. 100% of the participants in the world participate in healthcare in one level or another. And it's the largest industry that doesn't have a help desk. In fact, it doesn't use a CRM tool.
That's a new business model out there.
Absolutely. And if you think about it, what we kind of need, in answer to your question, you can kind of use the analogy of we need Apple Care. That's the telemedicine element, the ability to talk to somebody. We need the Genius Bar. We need the store to actually pick up and deliver and get us products. And at the end of the day, the stuff that happens in the back room where they fix our stuff, that's the hospital and maybe the back office of the medical office. So the kind of companies that are coming along today that are addressing the direct consumer need are actually going to start moving some of the physician and hospital role to the back, and up front actually start managing and owning the relationship, which is going to have interesting implications on where you go to get services. Because when they manage that relationship, they then are managing the direction of where you go and the answer to the question of what do I do next.
So Don, just to follow your model therefore, if the relationship with the consumer patient, and I'm going to use those two phrases interchangeably, if the relationship is not going to be with the hospitals, who is going to have the bigger chunk of the value in healthcare in the future? And I say that about it's not all about making money, it's about investment and who's going to have the investment. And those who have or create and capture the most value will ultimately have more of the power, more of the investment in healthcare. So if it's not the hospitals, because they're in the back room, they're not Apple Care, they're not in the Genius Bar, who are they?
Well, I think at the end of the day, it'll be entities that take on risk, whether it be in the form of bundled payments or full capitation risk, et cetera, to deliver some level of service. And whether that service is characterized as I'm going to keep you healthy, I'm going to make you healthy, or I'm going to fix what's broken. They can all come in any one of those flavors. But the entities that have the value are the ones that actually are going to step up and say, I'm going to take responsibility for that element, and not necessarily sit back and wait for you to show up at their door on a fee-for-service basis. And that's a big change. And we're seeing a lot of the new entities that are stepping up today. They're going to the employers, they're going to the payers and say, we'll take responsibility for X, Y, and Z. Give us a lump sum payment for it, and we'll become experts in that particular area. And if we need the specialty services of the back room, we'll go buy those services on a bulk rate purchase.
Okay.
If I could put a nuance on that, though, I do think that we need to, you said it, keep you healthy, make you healthy, or fix what's broken. I do think that the view on this will differ depending on which category you're talking about.
Sure.
You know, the keep you healthy or get you healthy, right, especially post-Christmas when we've all eaten too much, right, I think that is ripe for exactly what you're describing, to have a direct interface with the consumer to capture the value at that point, right, because obviously we know that the best way to save costs is to keep them healthy in the first place. I would argue from a time frame perspective, though, that at least over the next, I'll call it the next 5 to 10 years, fix what's broken, I think is still going to have a pretty direct connection between the patient and the healthcare service providers, right? I think that someone with cancer doesn't want to deal with a consumer app for the cancer. They want to go directly to an oncologist because, well, they could die in 3 months.
I actually agree with you completely. However, let's take what Walmart's doing in the marketplace. Walmart had for the last 6 years an optional program where if you were diagnosed with cancer as an employee or a dependent, you had the option of having a second opinion at Mayo Clinic. As a result of the last 6 years on the report out of the data, they have discovered that the local oncology providers weren't very good. And what they've now done is made review by Mayo Clinic mandatory, 100% across the board, and resulting in 30% of the patients now going to Mayo for their oncology care as opposed to the local provider. And that's what I mean by switching, redirecting the care. So essentially Walmart has basically said, if you put it in really blunt terms, we no longer trust the local providers. We're going to go to our designated expert. And the designated expert, based on the data we've collected, has shown that either the treatment plan you had, the diagnosis you had, or even the fact you actually had cancer was wrong.
Yep.
And so I think we're going to see more and more. Walmart's obviously a huge employer. Other employers are looking at that and going, whoa, what's happening? What do they know that we don't know? Well, what they know is they've got 6 years of data collected on 1 million associates and 2 million more dependents that they've now reported out on.
Yeah, and
So-
this is go ahead.
No, we could talk for a lot longer on this topic.
You and I
but
could have this conversation for days.
I do want to cover a couple of other areas. And we're talking more and more about data, but David, I mean, you've obviously now at Microsoft, you've spent a long time at Samsung, but data, I talk about the connecting, combining, and sharing of the insights. So the data integration and data interoperability, and we haven't quite got that fixed yet.
We're heading in the right direction, though. And
that's
so
very
that's the
polite.
good thing. And I'd say, you know, the promise of healthcare technology was originally around the ability for us to pull data together, be able to draw those insights, be able to move it freely, make it portable, accessible, understandable. We stumbled along the way. And in many ways, we've created silos. And the silos have established large businesses, which have fortified those silos. But the reality is, those silos are being broken down. There's legislation underway that are promoting standards, more specifically open APIs with Smart on Fire standards and other types of HL7 supported standards that are aligning organizations around common ways that we can communicate. So why is that important? Well, if you think of it from the perspective of the consumer, to be able to then gain access to your information anywhere, anytime, on whatever device or format, that's huge. I mean, it's similar to this whole concept of imagine if you were to go anywhere in the country or anywhere in the world and go to an ATM machine, you can pull money out from your bank. I mean, that's incredible. How did we do that? Because information was understandable, it was interoperable. That's the direction that we're trying to head into. But once we do that, then the real opportunity lies in terms of being able to understand what's behind all that data, and we can draw inferences and validate and become much more predictive in understanding who's at higher risk, who needs help, how do we be able to provide the right services at the right time. And that's an area that is really ripe for exploration. And as all the data sets become much more mature, cleaner, and are more interoperable, it gives us an opportunity to sort of rethink what's possible.
And Ron, just building on David's point about interoperability, and obviously Genentech is very formidable in drug discovery and also personalized care. What would be your nirvana in terms of that data interoperability?
Well, here's the world he just described.
Okay.
No, but
what impact would that
let me
make
give you some
for you?
practical terms, right? So, for example, there was an article published at ASCO, which is the big oncology society meeting every year in Chicago, right? It was published, I think, 3 years ago, and it showed that an app that actively tracked and managed a cancer patient's situation outside of the doctor's office. That app by itself, by informing the patient and by informing the physician of what's going on with the patient outside their office, that app improved their survivability on the drugs that they were on, right? I mean, I remember when I was outside the exhibit hall, I remember the presentation hall, I remember a doctor walking out going like, I thought I'd never see the day that an app cured cancer, right? That technology is not available broadly yet. And we're working with a company in Europe right now that is trying to do this, right? And they can't plug in to the EMR systems in Europe, right? And so no physician wants to have to deal with these different systems when they're making their decisions. So what you described for us is nirvana. You know, as these tools become increasingly available, we can bring it all together to make a difference to the patient at the point of care. So I think that's super important. The other reason for us, what you described as nirvana, is, you know, with the proliferation of both genomic, clinical, lifestyle data, you know, when you pull all of that together from a research perspective, we have more data than ever before in the history of human health, that to understand human beings and their disease at an incredible level of depth, right? And to actually then design therapies, not just drugs, but devices and other things to actually address this. It doesn't work if we only have fractions of the data, right? And that's one of the reasons that we have done our partnership with Flatiron and Foundation Medicine, right, to try to get access to be able to understand that data set. But, you know, you got Flatiron, 2 million patient records on oncology, right? Foundation Medicine, 400,000 genomic profiles. When we try to put them together, we only come up with 40,000 matched records. What you really need to understand human health is a large clinical genomic database, right? But you can't pull it together still. And I think what you're describing is what we need if we really want to take this to where it should get to.
And to tie it into our earlier conversation, if you are an organization that wants to take on risk, you need to have access to that data in order for you to be able to understand deeply what's happening and what will happen. And it's not just, I mean, the things you mentioned are absolutely correct. You know, we're talking about electronic health record data, we're talking about claims data, we're talking genomics, but also lifestyle data, social determinants of health. Those are also major factors that have a direct impact on patient outcomes and cost. And if there's ways that we can better understand those, we can address them more proactively.
Well, and Ron's hit on something that's really important, that's structural in the process. If a physician is going to prescribe something, it's got to be in their workflow. So if I'm going to prescribe a digital solution, maybe a drug app combination, I don't want to go to a separate siloed application to prescribe it. I've got to, number one, I've got to be able to literally hit the prescription, and the problem is I have more than dose and frequency to record. I actually may need the cell phone number of the patient to essentially prompt them to download an app, for example, as one additional piece of information. Maybe there's other levers I have to set as to when I want to be notified. And those are not in the system. We're starting to see it in the PBM system as Express Scripts has come out and said we're going to start building the formulary element of digital health, but we need the prescribing element of digital health, and then we need the back-end integration so that the results come back into the EMR in a way that are flagged to the physicians in a way that's appropriate.
Yeah,
So Don, we've got data nirvana, we've got the interoperability, we've got the app that's curing cancer. We haven't actually talked about the regulator. I've got a nice chart, I didn't show it today, in terms of AI regulatory approvals. And that path has been a bit sticky in the last few years. I know, Don, you and I were speaking about it just before Christmas. Where do you see the regulator going in all of this? Because healthcare still is a regulated industry, and it's the regulator is a very important stakeholder, be it the FDA or whatever, that we do need to bring into the party.
Well, there's a couple of semi-controversial things going on right now. One is the regulators are giving the smaller companies an easier pathway than large pharma. And that's intentional, but it's happening. And so they're letting...
It's quite disruptive.
It's disruptive. And so pharma is getting a more high level of scrutiny than the early guys, but the early guys, small guys, are being able to bring their products into market. But the other piece is a little bit controversial is we're going to start to see more trials that basically say, we don't actually know the electronic mechanism that's going on here. We don't actually know how this algorithm works. We don't even understand the code of the algorithm. So how are we going to prove that number one, it's effective, number two, that it's safe? Well, one of the things I think we're going to see more is trials against current practice today. Mm-hmm. Meaning, does the software outperform the marketplace? And if it does, then the question is, well, maybe we don't actually have to understand how it works. Now, notice in drugs that a lot of times we don't understand the mechanisms either. So, there's a precedent in the marketplace here. But I think we're going to see more trials that say, listen, if doctors get it right 90% of the time and the software is getting it right 94% of the time, maybe we don't actually need to know how the software is working as long as it's outperforming the alternative, whatever the alternative is. And we just saw that this week with Google and their AI on breast imaging.
Yeah, I think there's a difference also between artificial intelligence and machine learning. And if you think through an algorithm that's static, that allows you to be able to apply and validate it in a clinical trial, that's just like any other type of treatment that we have. But with machine learning, the complexity there is what you started with is not what you ended with. And that's where it ends up getting really confusing. And that's why these ongoing discussions that many of the technology companies are having with the FDA and others to really understand that process and understand how we can work together is so critical.
I agree.
And I would just add just real quick, I do think there is this, we see it also a bit of an evolution in terms of the thinking of where that is actually being applied. There's a big difference between, like the Google announcements, right? You may or may not have breast cancer, but then a physician has to go figure that out, versus an AI app that's operating in the setting of the ER, where you're trying to figure out, does someone have a heart attack or not, and do you give them a blood thinner immediately and create risk? Right, so I think as we evolve in the regulatory landscape, this is easier to manage because it's not a high risk, immediate life-threatening situation, and it's informative. I think when you get to the stuff that is high-risk, immediate, and life-threatening, I think there's more nervousness there, and I think we're going to see this evolve at different speeds as we go forward.
We are, but we do have some examples like artificial pancreases that are out in the market that are doing effectively exactly that. They're taking a high-risk situation, they're dosing the patient with a drug or a combination of drugs that too little or too much could be lethal.
Yep.
So we already have some precedent.
We absolutely do. I think I would argue, I think we would argue that in those kinds of settings, though, you really want more evidence in those settings than in the less life-threatening situations.
I agree.
Yeah.
We could go on all day, and I know we can't. Jill's got a busy agenda, but thank you very much, Don, Ron, and David.